Good evening, participants. Good evening, sir. I welcome you all to today's session of DHAMANI. We have the first session of DHAMANI today, and we are organized by Ayurveda Map and initiated by MedMap. I would like to say a few words about running courses. That is Diploma in Ayurveda Cosmetology. It is an upcoming course, which is a 6-month course. You will be getting online and offline classes. And in this offline session will be at Bangalore, and you will be getting a university certification for this. So if you are interested, you can contact us. And next one is DHAMANI. We have the first session of DHAMANI today, and we are providing the session for free for the participants and people who are interested to join DHAMANI. And if you're interested, you can contact us. If any of you are interested to join again, you can contact us. And we have an upcoming course that is Professional Diploma in Orthopedics and Sports Medicine Rehabilitation. This is also a 6-month course. You will be getting an NSTC certification with this. And this is also an online class. And also you'll have offline hands-on training at Daysman Hospital, which is at Kondoti. The session have started. We are giving this DHAMANI session as a bonus session for the PGDS, this PDO SMR participants. And if any of you people are interested in PDO SMR, to contact us. And our next course is Postgraduate Diploma in Ayurveda Nutrition. This is a 1-year course. This is a PG Diploma course. The classes will be starting from October, and the certification will be NSTC recognized, and the eligibility is BAMS only. And in this, you'll have 3 days offline. All the classes will be online classes only. So if any of you are interested in nutrition, Ayurveda nutrition especially, you can contact us. And next one, it is Rekha. The admission is open for Rekha. It is a certificate course in clinical management of common diseases in Ayurveda. We have just started the registration for Rekha. The course will be starting in September 2025, mostly 10th of September. And this is a certified course, university certified course. And for this also, you'll be getting the recording access of 2 years. And for DHAMANI also, we will be providing the recordings for 2 years. After the live session, you will be getting the recordings by next day, 12 o'clock. The recordings will be uploaded in the app website. Next, I would like to welcome our faculty, Dr. Shibu Varghese. He is BAMS, MD, FAGE, a lead Panchakarma expert with over 20 years in Ayurveda teaching, research, and clinical care. He is an author of best-selling books on radiological diagnosis and Panchakarma for spine disorders, treated renowned personalities and led landmark projects like Sahyayana and Sadhana, and presented 50 plus scientific papers across major Ayurvedic conferences and seminars. And he have been awarded many awards, and he's an eminent faculty in the field of orthopedics and radiological diagnosis. And I welcome you, sir, for today's session. Today's session is Clinical Interpretation of Radiology, Part 1 by Dr. Shibu Varghese. Over to you, sir. Welcome for the session.
Okay. Am I clearly audible?
Yes, doctor, you're audible, clearly audible.
Okay. So, very good evening to all. First of all, I'd like to thank Dr. Jasul for inviting me for this program. So, today's topic, as he already mentioned, it will be basically focusing on the radio diagnosis of spinal disorders, orthopedic, the basics of X-ray, how it has been invented, how to approach an X-ray, how to interpret an X-ray, etc. will be the main focus, and it will be revolving mainly focusing on the spinal disorders. So since the time is too late, I'll be just directly going to the session. So he is Mr. William Conrad Röntgen. He is considered as the father of diagnostic radiology. So his invention was an It's an accidental invention because when we are trying to experiment different types of vacuum tube. So on a vacuum tube, he has put an aluminum window over that. When he put on that aluminum window, he saw a shimmering effect on a board painted with the barium platinum kept near to this aluminum window. So he found that shimmering effect is because of some invisible rays which can penetrate to the harder substance, and that causes that shimmering effect on the board painted with the barium platinum cyanide. This is how he has invented this X-rays, as it was an incidental invention, we could say. So for his invention, he has got the first. This has been invented in 1895, and he got this Nobel Prize in 1901 in physics, the first Nobel Prize in physics for this invention. So this Mr. William Conrad Rondon, he was a very great man because after his invention, many companies have approached him saying that we'll give you this much of amount of money if you give a patent to this invention. But since he being a very good person, he didn't give patent rights to anyone, saying that the whole of the medical fraternity should use his practical application of the invention. So not only anyone, he has given the right for anyone, including Ayurvedic, homeopathy, anyone, you can use the practical applicability of his invention. This is how he has invented the X-rays. So what you are seeing, this is the first X-ray ever taken in the history. This X-ray demonstrates the hands of his wife, Anna Bert Röntgen. The second X-ray is an X-ray taken to show his invention in a public function. And after taking this X-ray, he was very much excited. The reason for the excitement is that after taking the X-ray, he could see that because this X-ray of the hand of her of his wife Anna Bert Röntgen. So this hand demonstrates his wedding ring. So after seeing this X-ray, he was very much excited. But unluckily, that excitement didn't last long because she divorced him after a few months. So before venturing into the intricacies of such an intriguing subject of radiology, it would be worthwhile to understand the basics of spine radiology. So as you know, the different structures in the X-ray can be identified because of the different densities these structures possess. So basically, there are 5 radiographic densities. They are in the order of increasing brightness. First is air, fat, fluid, bone, and metal. Here you can see a tumbler. In this tumbler, you can see the first is an air density, and second is this tumbler. The X-ray has been taken with the Tikta Gridam added to that. The 2 is a Tikta Gridam, that's a fat density. Third is a water density. 4 is a bone density, and 5 is the metal density. So in the X-ray, these structures can be differentiated because of the difference in the densities these structures process. As I said, the first is an air density, second is a fat density, third is a fluid density, fourth is a metal, and fifth. That's in the order of increasing brightness. So this is a very key concept of radiology. Also, one more thing you need to understand. So before taking an X-ray, the X-ray film will be white in color. So when X-rays falls on the film, it darkens it. So you can see the example with the help of this tumbler. So when more X-rays fall, so because air density, there is no much of the blockage of the X-ray. So more number of X-rays has penetrated to the air. So it becomes more darker. Before taking the X-ray, it is white in color. When more X-rays penetrated to the air, it becomes white. But as far as the metal is concerned, very less X-rays has been penetrated to the metal. So it appears more white in color. So this is a very key concept. So X-ray films before taking is white or transparent in nature. When X-rays falls on the film, it darkens it. So basically, there are 5 radiographic densities. They are in the order of increasing brightness: air, fat, fluid, bone, and metal. So this is a very key concept of radiology. So next is radiographic densities. So whenever you get an X-ray in your hand, make sure that first of all, you make sure that that X-ray belongs to the same patient, because in the clinics, one of the major problem which we face is that whenever a patient comes, they bring the X-ray of his wife, daughter, son, etc. So, and we will be a very good radiologist, or will be very good at interpreting the X-ray findings. But making a very proper diagnosis in a wrong patient will be very much embarrassing. So, whenever you get an X-ray in your hand, first thing what you have to do is that make sure that this X-ray belongs to the same patient. That was the first point. Second, in this X-ray, you can see you can see the lungs appears black in color because that's an air density, because through the lungs, more number of X-rays penetrates and it falls on the film. Second is you can see the fat density is little more whiter in color. So this is the breast shadow, which is little more brighter. That's the fat density. The bones appear, the heart appears little more whiter because it is a fluid density, because it is composed of the blood. Next is the bones, which are much brighter. That is a bone density, and you can see the safety pin over here. That's a metal density. So these different structures like the lungs, the heart, the breast shadow, the bone, as well as septic pin can be identified in the X-ray because in the difference in the densities these things possess. So this is a very key concept. There are basically 5 radiographic structure densities, and the different structures are being identified based on the difference in these densities possessed. Next is the clinic. One of the major problem we will face in the clinic is that we may send the patient for an X-ray, and when they come back with an X-ray, the X-ray may be either an overexposed or an underexposed. It may be either too much of darkened or too much of whitened in nature. That is called as underexposed or overexposed. Underexposed means very less number of X-rays has fallen on the film, and overexposed means too much of X-rays has been fallen on the film. So that is called as underexposed as well as the overexposed films. So here in the first X-ray, what you can see the tumbler is white in color because it is an underexposed. That means very less X-rays has been fallen on the film. So because of that, the borders are not very distinct. Also, in the second X-ray is an overexposed. That means more number of X-rays has fallen on the film. So the distinction between the air as well as the fluid is not clear. Also, the upper end of the bone is also not clear. So if it is either underexposed or overexposed, the distinction between the structures may not be proper. So we may land up, because the precision of the diagnosis may not be proper, and we land up in a wrong diagnosis or may not be able to make a diagnosis at all. So even if you get an X-ray like this in your clinic, make sure that tell the X-ray technician that I need a properly exposed X-ray, not an underexposed or an overexposed. So these are one or two artifacts or a difficulty which we face in the clinics with an X-rays. This is a radiology of the cervical spine. First of all, tell me actually, if you want to take an X-ray of the cervical spine, which projection will you prefer? Whether you prefer an anterior-posterior projection or a posterior-anterior projection. So whether to decide which projection we need to take, it depends upon the site of the structure which we need to be radiographed. Suppose if you want to take an X-ray of the spine, we should prefer AP view because the spine is situated in the posterior aspect of the body. So how you take an X-ray? So we will stand close to an X-ray film, and the X-ray beam will come from the front side. So if you want to get an X-ray of the cervical spine, we need to stand to X-ray film in the anterior posterior direction, because the spine is situated in the posterior aspect of the neck. So it has to be an AP view. But if you want to take an X-ray of a chest X-ray, it has to be PA view because the heart as well as the big blood vessels lies in the anterior. So to decide which projection, which X-ray need to be taken depends upon the site of the site which you are expected to take a X-ray. So in the cervical spine, it has to be anterior posterior X-ray because the spine is situated in the posterior aspect of the neck, and when we stand near to the film, the spine will be very close to the film. So that is how we prefer anterior posterior X-ray as far as the cervical spine is concerned. So this is how we take an X-ray of the anterior posterior view. Here the central beam is directed at the level of the thyroid cartilage at the C5 vertebral body. This is how we take an anterior posterior X-ray. So here you can see the anterior posterior X-ray. Second is the lateral projection. So lateral projection is also very similar to AP view only. So it is just at the level of the thyroid cartilage at the C5 vertebral body below the mastoid process. The central beam will be directed below the mastoid process in the level of the C5 vertebrae or at the level of the thyroid prominence. This is how a lateral X-ray has been taken. So this is a lateral X-ray. We will discuss on that later on. This is the Simmer's view X-ray. So as you know, the cervical spine is subjected to many traumatic injuries because it has got different directions in different magnitudes. So the lower cervicothoracic junction is subjected to many traumatic injury. So in the normal lateral view X-ray, when you take a lateral view X-ray, the cervicothoracic junction may be obscured by the shoulder shadow. So to get a proper view of the cervicothoracic junction, we go for a submerged view. Here the central beam will be directed just above the shoulder, like that of the lateral view only. Here, the advantage of submerged view is that we can screen the C7, T1 and T2. So the relationship between the C7 and T1 can be better seen in the submerged view X-ray. So I repeat, submerged view is taken mainly to screen the cervicothoracic junction or upper thoracic vertebrae. Because in normal lateral view, the cervicothoracic junction will be many a times obscured by the shoulder shadow. Next is an oblique view. The oblique view is very similar to that of the lateral view. Here, only thing is the difference is that the beam is obliquely placed. We can take either a right oblique or a left oblique depending upon the requirement. Here, the central beam is directed below the master process, but only thing is that the beam will be obliquely placed between 30 degree to 40 degrees. So an oblique view X-ray is taken. So this is an oblique view X-ray. It's a right oblique. There's an AP open mouth projection or an odontoid projection. It is mainly to screen the first and second cervical vertebra. That means it is mainly to screen the atlas and axis. As far as Ayurvedic doctors are concerned, this view is very important because in rheumatoid arthritis, atlantoaxial dissociation is quite common. So to screen the atlantoaxial joint, we need to have an AP open mouth projection where the atlantoaxial bones are clearly seen. Here the central beam is directed just below the incisor teeth. But one of the practical problems which we face in the clinic while taking an anterior posterior projection is that by the time we need to take an anterior posterior view, the rheumatoid arthritis will be set in and the temporomandibular joint will be completely fused. So patient will not be able to open the mouth completely and it affects the precision of the diagnosis. So that is called as AP open mouth projection. This is atlas and this axis, and this is the dens or an odontoid process. So here you can see this is called as an AP open mouth projection or an odontoid view. So this is the C2 vertebral body with the odontoid process. This is the lateral mass of C1 vertebral body. So normally the outer border of C1 as well as the C2 should be in the same line, and the odontoid process should be equidistant from the C1 vertebral body, and the odontoid process should have an uninterrupted cortical margins blended with that of the C2 vertebral body. So this is called as odontoid view. Suppose if a patient with the rheumatoid arthritis, if there's atlantoaxial dissociation is there, the outer border will not be in the same line. The C1 vertebral body will be outerly displaced like this, and the distance between the dens as well as the C1 vertebral body should be increased if there is a atlantoaxial dissociation seen in rheumatoid arthritis. These are hyperflexion as well as hyperextension views that is mainly taken following a trauma to assess the stability of the spine. This is a hyperflexion as well as hyperextension view. But if you suggest a patient to take a hyperextension or hyperflexion view, the patient themselves has to either flex or extend. That's called as hyperflexion as well as hyperextension views. This is an interpretation of an X-ray. So whenever you get an X-ray in your hand, normally what we will do, we will just look into the bone as well as the disc space. So that is not the proper way to interpret an X-ray. So X-ray has to be interpreted in terms of adequacy, alignment, bone, cartilage, disc, and soft tissue. So it has to be interpreted in ways of adequacy, alignment, bone, cartilage, disc, as well as soft tissues. So let's see what do you mean by adequacy. So normally, as far as the cervical spine is concerned, we call it an adequacy when the X-ray has got 7 cervical vertebrae. You can see the 7 cervical vertebrae are seen and cervicothoracic junction is seen. This is the T1 and CCSR. So it should contain 7 cervical vertebrae and cervicothoracic junction should be seen. And the bone should have a proper density, and you should be able to visualize the soft tissues as well. This is called as adequacy. Here in this X-ray, you can see this is an inadequate X-ray because in the first X-ray, you can see only 3 cervical vertebrae. In the second vertebra X-ray, you can see only 4 cervical vertebrae. This is an inadequate X-ray because X-ray should have all 7 cervical vertebrae, cervicothoracic junction should be seen. But here, the lower cervical vertebrae are not seen. Suppose if there is a pathology of the C5, C6, or C7, it will be missed in this X-ray. So here, what has happened is that the patient has shrugged the shoulder and it has affected the screening of the cervical vertebra. So in such condition, there are certain techniques with the technician where they will give some weight in the hands of the patient and they will take an X-ray. If you get an X-ray like this in your hand, send the patient back to the X-ray center saying that we need a properly exposed X-rays. So this is called as inadequate. This is called as adequacy. Next is alignment. So when you get an X-ray in your hand, you should draw 4 imaginary lines. One is the anterior vertebral line, that means in front of the vertebral body. Next is the posterior vertebral line, that is the posterior border of the vertebral body. Spinolamellar line, that's the posterior process of the vertebral canal, and the spinous process line. So these are the 4 imaginary lines you should draw when you get an X-ray in your hand. If you don't draw these 4 imaginary lines, you are likely to miss many step deformity, spondylolisthesis. If grade 1, if this vertebra is slightly slip different, if you don't draw a imaginary line, you are likely to miss up grade 1 spondylolisthesis. That's called as alignment. This is an example of a malalignment. Here you can see the 4 cervical vertebrae have been slipped different. Less than 25% has been slipped different. That is a grade 1 spondylolisthesis. So among the 4 lines, the second line is the best reliable line because it is least disrupted by the osteophytes. Here you can see because we had drawn a line, we got a step deformity. We could find out that there is a spondylolisthesis at this level. So this is called as spondylolisthesis or a malalignment. Next is the bony landmass. So when you get a cervical X-ray in your hand, your eye should screen the uninterrupted cortical margin of each and every vertebral bodies. That means your eye should follow the uninterrupted cortical margin of each and every vertebral body. Instead of seeing the vertebra as a whole, your eye should follow each and every end plates of the vertebrae. So as far as a bony landmark is concerned, vertebral body should be in the rectangular in shape. You can see the cervical vertebrae are all rectangular in shape and roughly equal in shape. But if you see the roughly equal in shape, the C3 and C4 is slightly smaller than the C2 as well as C5. So that's a normal anatomy. Also, the anterior height should roughly equal the posterior height. But if you see this X-ray, here the posterior height is slightly more than the anterior height. That is called as, that is a normal, because 3 millimeter height will be more in the posterior aspect compared to the anterior aspect. So this is a normal anatomy. That's about the bony landmass of the vertebral body. Second bony landmass, you can see the spinous process. So when you see a X-ray of the cervicus, you can see the size of the spinous process goes on increasing as we come down, because the spinous process of C7 will be bigger and the C6 will be a little smaller. The C5 will be more smaller. So like this, if you come down, the size will increase, and if you come up, if you go up, the size will decrease. That's about the spinous process. Second structure we need to look is pedicle. This is very, very important. Whenever you get an X-ray in your hand, you need to look into the pedicles, because the pedicles supports the articular pillars, or the pedicles connects the anterior part of the vertebra with the posterior part of the vertebra. Normally in osteolytic tumors and infectious causes, the first area which will be affected is the pedicle. So always look into the pedicle area. So this blue line which is already seen, this is called as the pedicles. This is the lamina. Laminas are not very distinctly seen on the X-rays. This is the facetal joint. When you get an X-ray, you can see the superior articulating facet as well as the inferior articulating facet. Many times, facetal hypertrophy, etc., can be seen in degenerative joints. So always when you get a lateral view X-ray, you need to look into the facetal joint. Third is the lateral mass. The lateral mass appears as a rhombo-shaped structure, projecting downwards and posteriorly. That's called as lateral mass. Then one more structure you may see in the X-ray, this is called as a double cortical line. So that is not a pathology, because normally when you take a lateral view X-ray, the lateral view X-ray may not be very clear. It will be slightly oblique up or down. That is called as double cortical line. This is not a fracture. It is because of the obliquity while taking the X-rays. So this is about the bony lamina. You have seen about the vertebral body. You can see the spinous process, pedicle, lamina, facetal joint, lateral mass as well as the double cortical lines. This is the pre-dental space. That's a space between the dents as well as the C2 vertebral body. This is called as the pre-dental space. So the space between the odontal process and the C1 vertebral body is called the pre-dental space. The pre-dental space should be 3 millimeter in diameter. If it is more than 3 millimeter, it indicates a fracture of the odontal process or a disruption of the transverse ligament likely. So that's about the pre-dental space or a cartilaginous space. Second is the disc space. The disc space should be symmetrical as we can learn. The disc space at the anterior part as well as the posterior part should be properly assessed. So you are all masters in assessing the disc space. Next, the soft tissue space. So normally when you get an X-ray in your hand, you don't look into the soft tissue space because there may be sometimes very subtle fractures or occult fractures will be there. It will be very hairline-like fractures which you may miss when you see the bony structures. But in such condition, the soft tissue structures give a clue about the occult fracture. So basically, there are three soft tissue spaces. One is the nasopharyngeal space that is in front of the C2 vertebral body. That's called nasopharyngeal space. The nasopharyngeal space should be 10 millimeter. Second is a retropharyngeal space between the C3 to C5, C3 and C4. That is called as a retropharyngeal space, and the distance should be 5 to 7 millimeter. Next is the retrotracheal space between C5 to C7, and the retrotracheal space is 22 millimeters. So normally, if the patient comes with a trauma, and if you observe, if the nasopharyngeal space is increased, it gives a clue that the C2 vertebral body is fractured, and we need to have a CT evaluation of the same. Second is the retropharyngeal space is increased, means more than if it is 5 to 7, then either C3, C4 or C5 vertebrae is been fractured. If the retrotracheal space is increased more than 22 milli, shows that C5, C6 or C7 vertebral body is fractured, and we should send for a CT scan. So here you can see the soft tissue space, it should be minimum. Here you can see the nasopharyngeal the retropharyngeal space should be 5 to 7 millimeter. So here it is more than 20 millimeters. So it is very evident that there could be a fracture at the C2 vertebra. If you observe very we can see a fracture line over here. But this may be missed in the X-ray, but this soft tissue gives us a clue that there is an underlying occult fracture. Next is interpretation of the AP view. So when you get an AP view, X-ray in your hand, how do we read the AP view? So whenever you get an AP view, you need to look into four things. First is the lateral mass. What you can see here near the blue line, that is the lateral mass. This lateral mass appears as a smooth undulating margins. This is called as the lateral mass. If there's a fracture of the lateral mass, that can be seen on the AP view X-ray. Second is the spinous process. This is the spinous process, this is the spinous process, and this is the spinous. The spinous process should be in the midline. It should be in the midline, and the interspinous distance should be symmetrical. If the spinous process aligned right or left, it indicates the unilateral facetal dislocation. Also, the interspinous distance should be symmetric throughout. The interspinous space should be symmetrical throughout. Next is the vertebral body height. The vertebral body heights on the left side, middle, and right side should be compared. If there is a compression fracture, this height will be reduced. So, next is the intervertebral disc space. The intervertebral disc space should be symmetrical in both the sides. That's called as AP. These are the four things which you need to look into the AP view. I repeat, one is the lateral mass, and second is the spinous process. Third is the vertebral body, and fourth is the disc space. These four things has to be noticed when you get an AP view X-ray in your hand. Second is the lateral view. So in the lateral view gives us the maximum information about the cervical spine. Here you can see the superior articulating facet or the occipital condyles can be seen. In the first C1 vertebral body, C2, C3, like all vertebrae can be seen. Intervertebral disc space can be seen. Intervertebral foramina can be seen. The superior articulating facet as well as inferior articulating facet can be seen. Then the spinous process can be seen. So almost all the structures can be very well seen in the lateral view X-ray. So these things has to be noticed when you get a lateral view X-ray. That means the vertebral body, intervertebral disc space, the vertebral foramina, superior articulating facet, inferior articulating facet, pedicles, a lamina, and spinous process has to be seen when you get an X-ray in your lateral view X-ray. Next is the oblique view X-ray. So oblique view X-ray is mainly taken if you suspect if you are having a pain in the neck radiating to hands. That means if there is a radiculopathy, it is better you take an oblique view X-ray because oblique view gives a clear picture about the neural foramina. Also, it gives a clear picture about the pedicles. So oblique view is superior to MRI and CT in assessing a pedicular fractures. So mainly the neural foramina as well as the pedicles and the epiphyseal joints can be better assessed with the help of the oblique view. This is the odontoid view. Odontoid view, as I said, is mainly to screen between the first and second cervical vertebra. The lateral border of the C1 should be in the same lane and the distance between the C1 and the dent should be symmetrical. This is trauma. So as Dr. Jasul has asked me to take a few points about the traumatic injuries because when you start a practice, the clinic, many patients may come with the trauma. So how do we approach the trauma? As far as the cervical spine is concerned, it mainly three types of trauma happens. One is some pressure applies to the vertex of the head, it means something falls on the head, or while carrying a weight on the head, if you slip, there will be axial pressure which occurs on the downward direction. It leads to a condition called the Jefferson fracture. Second is hyperflexion injury, especially when we dive into shallow water, etc. There will be hyperflexion and it leads to a condition called the teardrop fracture. And third is the hangman's fracture, which mainly occurs while attempt to hang or while having a road traffic accidents. There will be a hangman's fracture will be there. So this is called a Jefferson fracture. That means it's the fracture of the bony ring of the C1 vertebral body. Here, this we have to diagnose the Jefferson fracture. We have taken a AP open mouth view or an odontoid view. Here you can see this is the outer border of the C2 and this outer border. Normally it should be in the same line. Here the C1 has been displaced laterally. So by seeing this X-ray, we are very sure that there is a fracture of the bony ring of the C1. Also, the distance between the odontoid process and C1 is more. It's not symmetrical compared to this is called as Jefferson fracture. Second is the hangman's fracture. Hangman fracture is a hyperextension injury. Especially when you extend too much, what will happen? There will be a fracture of the C2 or there a pars interarticularis. You can see there's a fracture of the pars interarticularis and there's a displacement of the vertebra. If you draw a smooth line, you can see there's a step of deformity will be there. And also the prevertebral soft tissue has been increased. This is called as hangman's fracture. This is a teardrop fracture. That's a hyperflexion injury. It happens especially when we dive into a shallow water. And because of the sudden flexion, this is an avulsion fracture where there will be a fracture of the inferior segment of the vertebral body. This is called as teardrop fracture. Along with that, there will be a fanning of the interspinous distance and sometimes a spinal spinous process fracture also may be seen. This is called as teardrop fracture. There's the unilateral facetal dislocation. So normally, as I said, if you draw a smooth line here, you will get a step off. Here, one part of the vertebra slipped from. So I'll tell you how do you approach a facetal dislocation. So when you get an X-ray in your hand, divide the vertebra into four parts. First 25, second 25, third 25, and fourth 25. If less than 50% of the vertebra slipped from, we call it a unilateral facetal dislocation. So this unilateral facetal dislocation may happen from Ayurvedic doctors, Varghese, etc. Because it happens when the neck has been flexed and externally rotated like this. It leads to a unilateral. We call it unilateral. When less than 50% of the vertebrae slip front, we call it a unilateral facetal dislocation. Here you can see more than 50% is slip different. We call it a bilateral facet. This is definitely a surgical. We can't manage it. Next is cervical kyphosis. Many a times when a patient complains with the pain in the neck, we take an X-ray. So this is a normal X-ray because it has got a proper lordotic curve. As you know, the cervical spine has got a smooth lordotic curve, the thoracic spine has got a kyphotic curve, and again lumbar spine has got a lordotic curve. So this is the normal lordotic curve. Sometimes this lordotic curve may be lost and the spine becomes straightened. That is called as cervical kyphosis, or we call it a we call it a military spine. Normally, it should be the curvature. It may happen because of different reasons. One is because of a degeneration. So because of severe degeneration, what will happen? Sometimes the disc may collapse and the neck will tip front, and it pushes the neck backward. That is called as cervical kyphosis or a cervical straightening. Second is some congenital causes, like sometimes a patient may be born with the fusion of 2 or 3 cervical vertebrae. That is called as cervical kyphosis. Or due to some iatrogenic, while doing a surgery, if some part of the vertebrae has been damaged, it can also lead to a straightening of the spine called as cervical kyphosis. Or due to pathology, like if there is osteolytic tumors or any infective process, part of the vertebra will be damaged and causes a straightening. This is called as cervical kyphosis. So the second one is normal, and for the first one is called as cervical kyphosis or a military neck spine. Next is a cervical spondylosis. So how do we diagnose a cervical spondylosis? Normally in degenerative process, what will happen? There will be a destruction of the disc will be, the degeneration of the disc. So there will be narrowing of the disc space. If you see in this X-ray, you can see this C3, C4 and C4 disc space has been narrowed because there is a degeneration of the disc. So in cervical spondylosis, one is disc space will be reduced. Second is osteophytic lipping. You can see there is an osteophytic lipping is there. That's an adaptive process in degeneration. And third is marginal sclerosis. That means the borders of the vertebra or the superior articulating and inferior articulating will be more sclerosis white, which indicates a degenerative process. Here you can see reduced disc space, osteophytic lipping, marginal sclerosis, and straightening of the spine, and the bone mineral density is slightly reduced. So this leads to diagnosis of the cervical spondylosis. Next is a rheumatoid arthritis. As you know, you may be knowing that rheumatoid arthritis affects the fingers of the hand, or the metacarpophalangeal joint is the most affected. But the second most area which has been affected in rheumatoid arthritis is the atlantoaxial joint. So the disease process progress clinically and radiologically in tandem with that of the proximal joint involvement. I mean to repeat. So at the same time, the patient has got a erosion of the metacarpophalangeal joint or any inflammatory process. The same inflammatory process or the erosion will be seen at the atlantoaxial joint. Here you can see the atlantoaxial joint is completely fused. There is a thick pannus tissue seen, is completely sclerosed. The bone mineral density is completely lost. End plate irregularity is there. The vertebral normal alignment is completely lost. Here also you can see there is a osteophytic, there's a erosion at this level. Here you can see erosion, here you can see. Then the C1, C2 has been completely fused. The bony space has been completely damaged. So it leads to the diagnosis of an inflammatory arthritis, more likely to be a rheumatoid arthritis. Next is spinal canal stenosis. So a spinal canal stenosis, normally as you know, the cervical spine or the cervical cord rests in the spinal canal with a particular diameter. Normally it ranges from 18 to 22 millimeter. But on an average, if there is a narrowing of the spinal canal less than 13, we call it a spinal canal stenosis. Less than 13, minimal stenosis. If it is less than 10, we call it a moderate. And lesser than 8, we call it a severe spinal canal stenosis. Here you can see the spinal canal. There's no space. It's completely damaged because of the osteophytes. So plain X-ray has got a very limited role in assessing spinal canal stenosis, but such severe stenosis can be assessed in the plain X-ray. MRI is the better tool to assess a spinal canal stenosis. Here you can see the spinal canal has been completely narrowed because of a degenerative process. Next is the cervical rib. As you know, the rib starts from the thoracic vertebra onwards. Sometimes you may get to see a extra rib that is called as cervical rib or a neck rib or a supernumerary rib. This extra rib or a cervical rib causes a complaint called a thoracic outlet syndrome. So in thoracic outlet syndrome, two problems are happening or two pathologies are being happening. One is the lower trunk of the brachial plexus will be compressed between the first cervical rib as well as the scalenus muscle. So I repeat, the lower trunk of the brachial plexus will be compressed between the cervical rib as well as the scalenus muscle. Second is the subclavian artery. Along with the nerve, the subclavian artery also will be compressed between the cervical rib and the subclavian and the scalenus muscle and leads to a claudicatory symptom. So one is a neural compression and second is a vascular compression. So that is called as thoracic outlet syndrome. If there is a neural compression, what will happen? There it leads to atrophy of the muscles of the shoulder. There will be hypothenar wasting will be there, and numbness and tingling of the hands will be there. That's called as neurological. The lower trunk of the brachial plexus has been compressed. Second, if there's a vascular compression, that means if the subclavian artery is compressed, it leads to claudicatory symptom. Then how do we diagnose whether there is a intermittent claudication or a neurological claudication? If there is an intermittent claudication, go for one test called as a roots test. For that, what you have to do that you need to hyperflex and hyperextend the arm slowly and continuously for 3 minutes. After 3 minutes, there will be pain, swelling, and numbness. Pain and numbness on the hypothenar muscles or the hands will be there. That indicates a compression to the subclavian artery. So that is called as thoracic outlet syndrome due to a cervical rib. You can see, so normally the ribs starts from the thoracic vertebra. If it starts from the C-zone vertebra, that is called as cervical rib. Normally it also starts from the thoracic vertebra. The X-ray you can clearly see whether there's a rib, extra rib is there or not. Next is the thoracic spine. So the disease affecting the thoracic spine, cervical spine, lumbar spine is usually similar, but there are a few notable differences there because osteolytic tumors and compression fractures are more commonly seen in the lower thoracic spine. So thoracic spine is a very important structure because compression fracture as well as osteolytic tumors and certain infective processes like port spine are seen more on the thoracic spine. Let us see how do you take an X-ray of the thoracic spine. So here the central beam will be directed 2.5 centimeter below the sternal angle. This is called as thoracic spine. How to take an AP projection. This is an X-ray of a thoracic spine. This is an X-ray. Here you can see vertebral bodies can be seen, intervertebral disc space can be seen, and the ribs can be seen. In the AP view, these are the structures. If there is a scoliosis, right or left can be better seen on the AP view. There's a lateral view. Here the central beam is directed laterally, just 2.5 centimeter below the sternal angle. So in the lateral X-ray, you can see the vertebral body from thoracic 1 to thoracic 12. Intervertebral disc space can be seen, intervertebral foramina can be seen, and the dome of the diaphragm can be seen. These are the structures which can be seen on the lateral thoracic X-ray. Next is the compression fracture of the thoracic spine. As I said, normal. Suppose if a patient above 80 comes to you and says that I had a fall, just had a fall on the ground actually without much force. I simply just slipped and slightly the buttock hit. In such condition, if it is an osteoporotic patient, definitely take an X-ray of the thoracolumbar spine because usually people will take an X-ray of the lumbosacral spine. That's not the proper way. The patient has a history of a fall by hitting a buttock. You need to take an X-ray of the thoracolumbar spine to rule out a compression fracture of the lower thoracic spine because lower thoracic spine is much affected with a compression fracture. Here you can see the height of this is the normal height. Here you can see the anterior height is reduced compared to posterior height. This is called as a compression fracture. Here also you can see the anterior height is lesser than the posterior height. This is called as compression fracture. This is a normal X-ray. So the lower thoracic is T10, T11, and T12 is the area which has been more fractured following a fall. So any patient above 70 had a history of a fall hitting the buttock to take an X-ray. You should refer that thoracolumbar X-ray to screen. Thoracolumbar X-ray has to be taken. If there is a compression fracture, if there is no neurological deficit, you can manage the patient. You can advise the patient for almost 1 to 2 months of complete bed rest, and patient will be all right by then. This is the lumbar spine. Here you can see the height is lesser than the horizontal. This is horizontal. This height. The height will be lesser than the horizontal diameter. That is the normal anatomy of the lumbar spine. And height is similar to adjacent one. Like unlike in cervical spine, the height is different, but here the height is almost similar in almost all the vertebrae. Next is the disc height. You know, the radiolucent shadows between the vertebral body is called as the disc, and there will be a progressive increase in height above downwards. As you come down, there will be a progressive increase. The height will be there, except between L5 and S1. The L5 and S1, the disc space will be slightly reduced compared to other. Normally from L1 onwards, L1, L2 will be having, if suppose 1 centimeter the height of L1, L2, L2, L3 will be little more like this. But as come at the L5, S1, the disc space will be reduced. Next is the spinous process. It's very important. You need to look into the spinous process. The spinous process will be seen in the midline, and the interspinous distance should be symmetrical. If the interspinous distance is 1.5 times more, it indicates a unilateral facetal dislocation. Second is the pedicles. This is a very important structure which you should never miss out when you read an X-ray. And this is, pedicles are oval-shaped structure. This is oval-shaped structure. You have to look into all the pedicles when you get an X-ray, because earlier signs of an infection or the earlier sign of an infection could be seen at, or osteolytic tumors will be seen as a pedicular destruction. Could be seen as a pedicular destruction. So in the AP you can see as a oval-shaped shadows on both the sides. These are the pedicles. But my request is never miss to see the pedicles, because you may diagnose sometimes an early osteolytic tumors or a earlier Port's spine by looking into the pedicles. You'll come to know as the slide progress what is the importance of pedicles. You'll come to know. The lateral view, it can be seen as a rectangular in shape. This rectangular shape can be seen. This is the facetal joints. Facetal joints are linear oblique radiolucent shadows. These are linear oblique radiolucent shadows. This is called as the facetal joints. Next, the pars interarticularis. The pars interarticularis is a region between the superior articulating facet as well as the remainder of the lamina. This pars interarticularis is very, very important structure, because the spondylolisthesis or the slippage of vertebra may be because of a fracture of the pars interarticularis. So, as radiological of the lumbar spine is concerned, reading the pars interarticularis is very, very important. So this is an oblique view. So here this is an oblique view of the lumbar spine. Here you can see a dog is there. You can see the mouth of the dog. This is the leg of the dog. This is the body, and this is the ear. So this dog is called as the Scotty dog. So the neck corresponds to the pars interarticularis. This is called as the pars interarticularis. In the back slide you can see. So the area between the superior articulating facet as well as the inferior or the remainder of the lamina. This is called as pars interarticularis. If you take an oblique view X-ray, you can clearly see it as the neck of the Scotty dog. This is called as pars interarticularis. This is the transverse process. It's apparently seen on both the sides of the vertebra. You can see this is called as transverse process. There's the articular surface. Always look into the articular surface. This articular surface is a smooth sclerotic surface of the vertebral body. You need to look into the articular surface as well, because that's very, very important. The gas shadows, these are the black shadows. These are not osteolytic areas, because these are a gas shadow from the bowel. It may create a confusion when we read the lumbar spine X-rays. Next is the Cupid's bow contour. So normally the inferior end plate should be straight like this. This is a normal inferior end plate. Sometimes there could be a normal variant. Means it's not an abnormality. Few of the patients will be having a non-flat inferior vertebral body. This is a flat vertebral body. This is not a flat. This is called as non-flat, non-flat inferior end plate of the vertebral body is called as Cupid's bow contour. or it resembles. See, this is a flat, this is a non-flat. This is called as Cupid's-bow contour. So it resembles like that of a double curve of the human upper lip. It resembles that of a double curve of the human upper lip. This is called as Cupid's bow contour. It's not a pathology, it's a normal variant. So few percent of the patients will be having this Cupid's bow contour. There's a Soya shadow. When you take an X-ray of the lumbar spine, you need to look into the Soya shadow. Please remember this. This is got a very clinical significance. Is that you can see this is a shadow seen on both the sides of the lumbar spine. This is called as Soya's shadow. This is called as Soya's shadow. So here in this X-ray, you can see a Soya shadow on the right side, but left side is completely absent. It indicates that there could be some infective process over here. Thereby, the transudate or the pus drains through the Soya sheath and obliterates the Soya shadow. So many a times a port spine or an osteomyelitis causes any pus drainage from the upper spine will cause a obliteration of the shadow of the Soyas. This is called as absent Soya shadow. This is called as lumbosacralization. Normally, the transverse should be free like this. In this lumbosacralization, you can see the transverse was is fused with that of the sacrum. This is called as lumbosacralization. So normally this lumbosacralization, there are two schools of thought. Certain people say that the lumbosacralization will not cause a pain. Certain people say that it causes a pain. But in my clinical practice, I feel that the patients with the lumbosacralization will have a pain because of two reasons. Because when the L5 vertebra is fused with the sacrum, what will happen? That the L4, L5 level, there will be more mobility will be there. It leads to a damage of the L4, L5 disc. Also, normally, here you can see this is a lumbosacralization. Normally, the disc will be this much of thick. But in lumbosacralization, the disc will be thin and it can lead to earlier bulges. So this is called as lumbosacral. This is a case of a unilateral lumbosacralization. Sometimes there can be even a bilateral lumbosacralization will be there. So in the X-rays, you can see like this. Here it's free. Here it is fused. This is called as lumbosacralization. This is called as lumbarization. Normally, see, if you see this picture, you can see lumbarization means there's a failure of the S1 to fuse. Instead of S1, normally the S1 will be fused with that of the sacrum, but sometimes this L1 will not be fused with sacrum. So we call it an L6 vertebra, that is called as lumbarization. Normally, 5 lumbar vertebrae and 5 sacrum will be there. Here, in this X-ray, what has happened? It's a sacralization. Here, instead of the free transverse process, the sacrum has been fused. The S1 segment has been complete. The L5 segment has been completely fused with that of the sacrum. That is called as sacralization. This X-ray, you can see lumbarization because instead of 1, 2, 3, 4, 5, this also been this is called as lumbarization. This is the degenerative joint disease. So this is an X-ray of the thoracic spine. Here you can see there is a depression of the vertebral end plate. This is called a smallest node. This is an X-ray. This is an X-ray. Here you can see there is a protrusion of the disc space into the vertebral body. This is called as smallest node. Here, that means there is a protrusion of the disc space into the weakened part of the vertebral end plate is called as smallest node. The MRI can detect the so MRI can detect the smallest node at a very earlier phase. X-rays, it is very difficult to see that because in severe smallest nodes can be seen, but MRI can detect an smallest node at a very earlier phase. So it is nothing but it's a protrusion of the disc material into the weakened part of the vertebral end plate. That is called as smallest node. Here you can see lumbar spondylosis. Here you can see there is an osteophytic lipping. There's an end place has been whitened, that is called as sclerosis, and a sharp projecting osteophyte. This is called as lumbar spondylosis. This space narrowing and the vertebral end place is sclerosed, osteophytic lipping is there, and there is a degenerative scoliosis. So it gives the diagnosis about the lumbar spondylosis. This is another example. Here you can see a sharp projecting osteophyte. This is called as osteophytic lipping. Actually, this is an adaptive process to prevent the disc from bulging out. Here you can see a osteophytic lipping or a beaking, we call it a beaking. There's a scoliosis, that's called a degenerative scoliosis, and reduced disc space. That means you can see the interspinous distance has been reduced. In this X-ray, you can see the disc space has been reduced, osteophytic lipping, sclerosis or whitened of the end plates. The similar here. So it gives an impression about the degenerative joint disorder or lumbar spondylosis. So in lumbar spondylosis, one is a disc space reduction, marginal sclerosis, as well as osteophytic lipping will be there. Based on this, we can diagnose a lumbar spondylosis. Next sign, what you can see in the degenerative disease of the lumbar spine is a vacuum phenomenon. Here you can see a black shadow here. Normally, such black shadows are not seen between the vertebrae. It is called as vacuum phenomena seen in degenerative disc disease. In infective disc disease, this will not be seen. So this vacuum phenomena or a radiolucent shadow seen between the vertebra is a sign of a vacuum phenomena associated with the degenerative joint disorder. This is a fish vertebra sign. As you know, normally the vertebrae are rectangular shape with a flat end plate. Here you can see biconcave disc space of the vertebra. This is seen in gross demineralization or severe degeneration, severe osteopenia. This fish vertebra sign or biconcave disc space, disc-like structure of the vertebra will be seen. This is called as fish vertebra sign. Next is empty bone sign. So normally, you know, there is a trabecula will be there for bone. Here, in severe demineralization, degeneration, what will happen? There will be a the bone mineral density will be reduced, and this vertebra appears as an empty box. Only there will be a reinforced peripheral trabecula with a loosened center. This here you can see a reinforced peripheral trabecula with a loosened center. Looks like that of a empty box, as if nothing is there. This is called as empty box, and this is also a sign of a degenerative joint disorder. There's a verticalization of the trabecula. Normally, you know, in normal bone, there will be vertical trabecula and horizontal trabecula will be there. Vertical lines and horizontal trabecula. That is how the bone is made up of. In severe degeneration, what will happen? There will be accentuation of the horizontal trabecula will be there. Only the vertical trabecula stays. Only the up and down lines will be seen. The sideways line will not be seen. This is called as verticalization of the trabecula, seen in case of severe gross demineralization. Suppose if a patient falls, definitely there is a possibility of a compression fracture because it is not being properly reinforced with the horizontal trabecula. Only vertical trabeculas are there. This is called as verticalization of the trabecula. There's a spinal canal stenosis. As I said, normally it will be very difficult to diagnose spinal canal stenosis in plain X-ray. Here you can see there's a normal spinal canal. But here if you see, you can see there's an osteophytes projecting into the spinal canal. So if you take an MRI like this, you can definitely see there'll be narrowing of the spinal canal, and spinal canal stenosis can be expected. We can assume a spinal canal stenosis because you can see there's a posterior projecting osteophytes into the spine. Here you can see this is a normal vertebral canal. Here it's not a normal. It's been narrowed because of the osteophytic lippings into the spinal canal. Along with that, there will be disc also will be. So disc osteophytes will definitely cause a narrowing of the spinal canal. This is called as spinal canal stenosis. But it's always better to take an MRI to screen for a spinal canal stenosis. But X-rays also gives a clue if you see an encroachment of the osteophytic lippings in the spinal canal. This is autoimmune disease of the spine. So suppose if a patient in 20s, suppose if there is a patient in 20s complains of a pain in the low back, or especially pain in the sacroiliac joint with a difficulty in bending, and if there is a pain in other 3 joints, oligoarthritis, because 2 or 3 joints, there will be pain and severe joint pain with the sacroiliac pain. What will be diagnosis? You have to always suspect about the possibility of an ankylosing spondylitis, because in patients in the second decade and the 20s or 30s complaints of a severe sacroiliac pain with the pain in other 2 or 3 joints with the severe early morning stiffness, you need to suspect about the possibility of an ankylosing spondylitis. Here in this X-ray, what you can see, if you suspect an ankylosing spondylitis, you have to take an X-ray of the sacroiliac joint. There will be sacroiliitis will be there. This is an X-ray of a patient who has been recently diagnosed with the ankylosing spondylitis or sacroiliitis. Here you can see both the sacroiliac joints, there is a sclerosis, widening of the joint space. Widening of the joint space will be seen in the initial phase because there will be inflammatory edema of the cartilage will be there, and widening of the joint space with the marginal sclerosis. This is a case of a sacroiliitis, initial phase. This is a sacroiliitis of a later phase. You can see the joint space has been completely distracted and there's a fussiness of the joint mark. Here this is a case of a sacroiliitis. To diagnose the sacroiliitis, MRI is better because MRI can detect early sacroiliitis. X-ray may take little time for that to diagnose. So you can see the joint space has been obliterated, fussiness of the joint margin, and the subchondral sclerosis. So there is a sacroiliitis. As the patient, as the disease advance, what will happen later? If you take an X-ray of the spine, you can see there will be bridging between the spine. You can see there's a bridging between the spine will be there. Then there is some erosion is there. Obliteration of the joint space will be there. And vertebrae appears squared rather than a rectangular. Usually it appears as squared. Here is a typical bamboo spine. A very advanced disease, you can see it appears as a clear bamboo-like appearance. In the neck also, you can see a completely fused single segment of the bone. Here you can see a wiring. So normally if a patient with ankylosing spondylitis comes, you may say that it's very stiff. You may try to manipulate it. Never ever try to manipulate because it may lead to a fracture called chalk stick fracture. And ultimately wiring and other things has to be done. So never try to manipulate patients with the ankylosing spondylitis. This is a full bone ankylosing spondylitis. This another sign seen in ankylosing spondylitis. Here you can see there is a central radio-opposite. This is called as dagger sign. Is mainly because of the calcification of the supraspinous as well as the interspinous ligament. This is called as dagger sign. It appears like that, a dagger, a sharp projecting dagger, mainly because of the calcification of the supraspinous as well as the infraspinous ligament. Also, there's a trolley track sign. You can see there's a central 3 lines, first, second, as well as third lines. The first and third lines is mainly because of the calcification of the epiphyseal joint, and the second line is mainly because of the calcification of the supraspinous as well as the infraspinous ligament. This is called as trolley track sign. And the lesion called the Romanus lesion. So normally there's a shiny corner of here. You can see the vertebra. There's a shining of the corner of the vertebra. This is called as a Romanus lesion. Actually, it's an endosopathy. Endosopathy means the at the site where the ligaments and tendons attaches the bone, that is called as endocyst, and the inflammation at the site is called as endocytis. So this shining sign is mainly because of the endocytis, which occurs as a part of the ankylosing spondylitis. So this is called as a Romanus lesion, another distinctive sign of ankylosing spondylitis. Another disease called the diffuse idiopathic skeletal hyperostosis. Here you can see this is called as diffuse idiopathic skeletal hyperostosis. So here in diffuse idiopathic skeletal, we can see sharp projecting osteophytes outside in the lateral view. And in the AP view, one of the specialties, this sharp projecting osteophytes will be seen only on the right side. The left side will be clear. The right side, there will be sharp projecting osteophyte, because the left side is assumed to be because of the presence of aorta, etc. Body has made a adaptive process not to have a sharp projecting osteophyte at this side. On the right side, if there is a sharp projecting osteophytes, it will be outward projecting. Here you can see these are all outward sharp projecting osteophyte. This is called as a diffuse idiopathic skeletal hyperostosis. So by seeing this X-ray, can you diagnose what clinical condition it would be? If anyone can diagnose by seeing this picture, you can unmute and say the answer.
Is it psoriatic arthritis?
Definitely it's psoriatic arthritis. Why so, sir?
I'm sure the picture of nails are explaining.
Definitely right answer. Good. Here you can see in the finger, you can see this called as dactylitis, or a sausage-like finger will be there. And you can see in the X-ray, you can see this is called as pencil in cap appearance. This pencil and cap appearance is mainly seen in psoriatic arthritis, mainly because of the erosion of the bone. There will be a sharp thing in the, this is called as pencil in cap appearance. That's very typical of a psoriatic arthritis. Also, you can see there's arthritis mutilated. There's an erosion of the distal, because in psoriatic arthritis, the distal interphalangeal joints will be affected. But if it is a rheumatoid arthritis, the proximal interphalangeal joints will be affected, or metacarpophalangeal joints. When distal interphalangeal joints are affected in psoriatic arthritis, along with the nail changes are there, then there is a supracalcaneal bursitis will be there. So these clinical signs are very obvious for a psoriatic arthritis. One is in psoriatic arthritis, there will be severe erosion will be there, bone erosion, and but two distinct features will be there in psoriatic arthritis. One is the erosion, as well as a new bone formation will be there. Erosion and new bone formation will be there, along with the dactylitis, supracalcaneal bursitis, and the onychulitis, and all these are the changes. And radiologically, pencil in cap appearance will be there. So this is the patient of a psoriatic arthritis. There's a bulky osteophytes in the vertebra. This is why I said there will be always new bone formation will be there, and you can see there is an erosion of the bone. So new bone formation with the erosion is a very typical of psoriatic arthropathy. This is an X-ray. You can see there's a new bone formation along with the lytic lesion. So new bone formation with the lytic lesion is very typical of a psoriatic arthropathy. Suppose if a patient in her 70s or 80s complains of severe low back pain or severe pain in the spine, which worsens in the night, along with the anemia and recurrent infections. What could be a diagnosis? I repeat, you may unmute and say, suppose if a patient in 80s complains of spinal pain worsen in the night hours, along with the recurrent respiratory tract or urinary tract infection and anemia. What will be your diagnosis?
Prostatic carcinoma.
It's not prostatic carcinoma.
Okay.
Anyone else? It could be a primary malignancy of the bone that is called as multiple myeloma. Usually, a patient with the multiple myeloma will have a recurrent urinary tract respiratory infection will be there, anemia will be there, severe bony pain, especially the spine pain will be there, which will be worsening in the night hours will be there. So if you suspect a multiple myeloma, you have to take an X-ray of the spine. Here you can see multiple collapse of the vertebrae, collapse of more than one vertebral bodies. But one interesting thing is that even though there is a multiple collapse of the vertebral body, the disc space is preserved. That's one of the hallmark of multiple myeloma. Along with it, you can see erosions here. Multiple collapse of the vertebral body with erosions, but apparently no disc space reduction. This X-ray, you can see multiple collapse of the vertebral body, and the vertebral foramen has been enlarged, and the disc space is maintained. Here you can see paraspinal soft tissue swelling. So these are very distinctly seen in multiple myeloma. This is one of my patients. Okay, we'll discuss it later. If you say, based on the plain X-ray, so based on the X-ray of the spine, if you got a doubt about the possibility of a multiple myeloma, you have to take an X-ray of a flat bone, either of a pelvis or a skull. The pelvis or a skull, if a patient is having a multiple, you get to see a puncture out lesion. You can see puncture out lesion or a raindrop appearance or a moth eaten pattern. In degenerative disease also such raindrop appearance, but there will be a ring-like sclerosis will be. So a lesion without ring-like sclerosis, which appears as a raindrop appearance or a moth-eaten pattern, then it is called as your diagnosis of multiple myeloma will be confirmed. So that's about the multiple myeloma. So anyway, I will be taking a class on magnetic resonance imaging. That time we'll deal more about how to diagnose a multiple myeloma and other things. But here it's a primary topic about the radiological or the X-ray of the spine only. So regarding the detailed diagnosis of multiple myeloma, we'll discuss at that time. So in radiologically, this machine, there will be multiple collapse of the vertebrae will be there. Enlarged vertebral foramina will be there. Paravertebral soft tissue swelling will be there like this. Then moth-eaten pattern of the skull or a pelvic bone will be there. That's how we diagnose a multiple myeloma radiology. This is the ivory vertebral sign. Just now you said that there's a prostatic cancer. If there's a prostatic cancer, the secondary symptom, because that's an osteoblastic metastasis. So normally, if it is metastasis to spine, if you take a plain X, you will get an ivory vertebra. Ivory vertebra refers to an increased opacity of the vertebra without any change in the size and shape of the vertebra. That means a sclerotic or a white vertebra without any change in the size and shape of the vertebra compared to that. This one, this is called as ivory vertebra sign. It refers to a secondaries of the spine, mainly seen in prostatic carcinoma. This is a patient of an ivory vertebra, which I have taken an MRI, and MRI shows a metastasis, and this is a PET scan. PET scan shows a deposit at multiple sites, which he already had a multiple deposits. This is a patient of mine. He has paid after 8 years of treatment. Suppose if a patient complains of any patient, it can be a young patient, middle-aged patient, or an old-age patient, complains of a focal vertebral pain. That means at a particular site of the vertebra, if there is a severe pain associated with the evening rise of temperature, and the pain is unremitted by change in any position, what will be your diagnosis? I repeat, a focal vertebral pain worsening at night hours, unremitted by change in the position, associated with the evening rise of temperature. What will be your diagnosis? So there will be a tutorial at the end of this class, actually. So please be careful so that I'll be asking questions. You will get a chance to answer. Anyone? Focal vertebral pain.
Participants are answering tuberculosis, sir.
Okay, fine. So definitely that is called a sports pain or a tuberculosis. If you suspected tuberculosis, you have to take an X-ray. And if you take an X-ray, what you can see is that you'll definitely see there is a collapse of the disc. This collapse will be there. Then there will be a paravertebral soft tissue will be there and fusion of two vertebrae. This another X-ray you can see there is a erosion seen because while taking a class I said actually you should look into the pedicles. Here you can see a pedicle. Here you can you see a pedicle here? There is a pedicular destruction which is a hallmark of a port spine. So that is why I said whenever you get an X-ray, you need to look into the pedicles. Here both the pedicles are intact. Here its pedicles are destructed with a lytic lesion. Here you can in this second X-ray, what you can see there is a disc space. It's been completely destructed, and there is no end plates are seen. There's a end plate destruction, is the fusion of two vertebrae. This X-ray by seeing that is very sure that it's a case of a port spine. Mauricio, please unmute your mic.
Yes, sir.
Okay. Second is a missing owl sign. Here you can see on both the sides you can see the pedicles. Here pedicles is not seen. This is called as missing owl sign, which is seen in port spine. So that is why I said always look into the pedicle, because the early sign of any osteolytic tumors or a infective lytic lesions appears as a missing owl sign. If the tuberculosis is not diagnosed in time, what will happen? It leads to a destruction of the bone or a collapse of the bone, and which leads to a sharp angulation of the spine that is called as port spine gibbous. You can see there's a port spine gibbous. It can be seen from outside as a projection and swelling. This is called as port spine gibbous. This is a metabolic disorder of the spine. Here you can see the vertebra has become sclerosed or white in color with a vertebra because enlarged. Because in Paget's disease, it's a metabolic disorder of the spine where there will be increase in the osteoclastic activity and osteoblastic activity. Because normally, when few of the osteoblasts are the one which forms a bone, osteoclasts are the one which destructs the bone. So initially there will be a destruction of the bone. That means there will be osteoclastic activity, and later there will be osteoblastic activity, which leads to a deformed and enlarged bone that is called as Paget's disease or a sclerosed bone. This is, you can see, sclerosed and enlarged bones, which can be seen in Paget's disease. Here also you can see sclerosed and enlarged bones. It's called as Paget's. It's a metabolic disorder. And if you take an X-ray of the skull, you can get to see a cotton wool appearance, because in cotton wool appearance, what will happen? There will be more of the calcium deposits and destruction. So inorganized or disorganized destruction and deposition of the calcium leads to a cotton wool appearance. Here you can see this is a very typical cotton wool appearance because of the increased osteoblastic and osteoclastic activity seen in Paget's disease. To take an X-ray of the spine in Paget's disease, you can see you can get to see a picture frame appearance. That means a reinforced peripheral trabecula with a loosened center, like this, like similar to that of a picture frame. Outside there will be white and inside there will be black. This is called a typical picture frame appearance seen in case of Paget's disease, which is very specifically seen in Paget's disease. This is a gouty arthritis. As you know, in the present clinical practice, you get to know because of the lifestyle, today people take too much of alcohol, too much of protein, too much of non-veg, etc. leads to increased uric acid production, and uric acid leads to a gouty arthritis. In gouty arthritis, there will be punctured out sharp lytic lesions will be there with the overhanging margin. You can see a punctured out lesions with the overhanging margins. That's very distinctive of a. Here also you can see there's overhanging margins with the destructive lesion, very much seen in case of gouty arthritis. This is a case of a severe gouty arthritis. If it is not taken care in time, it leads to severe destruction of the bone. But there will be always a punctured out lesion with overhanging margins will be there. Next, this is called alkaptonuria. Suppose if a patient in the 15 years or 17 years complains of pain, severe pain in the lower back, when you take an X-ray, if you see a disc calcification like it, because disc calcification is seen only in alkaptonuria. Alkaptonuria is a metabolic disorder where there will be a defect in the thyrosin metabolism. As a result of defect in the thyrosin metabolism, what will happen? There will be an increased homogenetic acid in the body, and homogenetic acid will destruct the cartilage because of a reduction of the homogenetic acid peroxidase enzyme, and it leads to increased homogenetic acid in the body. So because of the increased amount of homogenetic acid, it leads to a condition called a disc calcification and destruction of the cartilage. This is also called as black urine disease. When the urine is exposed to oxidation or atmospheric air, it turns into black. Or if you take a earwax of a patient with the alkaptonuria and exposed to air, it turns into black. That is called as alkaptonuria. This is spondylolysis. As I said, there's a structure called the pars interarticularis. And normally, sometimes if you don't take folic acid, etc., there will be during the pregnancy time, what will happen? The child will suffer from a defect in the pars articularis, or there is a fracture of the pars interarticularis, and that condition is called as spondylolysis. A fracture of the pars interarticularis is called as spondylolysis. Here you can see, as I said, in the oblique view X-ray, if you take this, a normal Scotty dog, this is the neck. Here you can see there's a defect in the neck. This is called as spondylolysis. This X-ray is more clear. In this X-ray, you can clearly see a Scotty dog, and the neck corresponds to pars interarticularis. Here you can see the neck is absent. There's a fracture of the pars interarticularis, and that condition is called as spondylolysis. This is called as spondylolisthesis. Here what you like, because of the spondylolysis, this vertebra has been slipped to front. Grade 1, this vertebra was slipped front, which is called as spondylolisthesis. The spondylolisthesis will be grade 4. So if one part of the vertebra is slipped to front, it is called as grade 1 spondylolisthesis. Here, if two parts is slipped, this is called as grade 2. So likewise, 3 and 4 will be there. If 4 parts has been, because the vertebra has to be divided into 4. First 25, second 25, third 25, fourth 25. One part is slipped front, it is called as grade 1 spondylolisthesis. Next is scoliosis. So the right to left bending of the spine is called as scoliosis. Scoliosis, if a child, usually females at the age of 11 or 12, if they come with a scoliosis, if they bend of the spine, that is called as idiopathic adolescent scoliosis. That in scoliosis, how to measure the scoliosis? There's an angle called the Thorpe's angle. What we need to draw a line from the maximum tilted vertebra like this, from the like this, and there will be an angle formed that is called as Thorpe's angle. The Thorpe's angle is less than 30, we can conservatively manage. If it is more than 30, the patient has to be subjected to surgery before the age of 18 years. So if a patient with the scoliosis comes to you before the age of 18, you need to evaluate the Thorpe's angle and advise whether the surgery is needed, because before the ossification is completed, surgery has to be done. Then only the success rate will be more. This is called as adolescent idiopathic scoliosis. This case is a case of scoliosis, but here you can see it is because of the disc has been collapsed. It's called as degenerative scoliosis. So next is called as spina bifida. As I said, normally during the pregnancy time, the mother has to take a lot of folic acid. If the mother does not take a folic acid, leads to a condition called neural tube defect. So if the neural tube defect is what will happen, the spine will not fuse together. Here you can see there is a gap between the spine. Here the spine is completely fused. Here it is not fused. Here also you can see this is the spine, this another part of it is not fused. This is called as spina bifida or spina bifida occulta, because the spine process has been not completely fused. Here this another example you can see. This is a normal spine. Here the spine is not fused. This spina bifida occulta. Here also the spine is not completely fused. Here also it is not fused. This is called as spina bifida occulta. Spina bifida occulta patient will have a pain. If you observe the back of the spina bifida, you can definitely see a tuft of hair will be there, and there will be a fat stranding will be there. And beneath that, this is called as spina bifida occulta. So here ends the topic of X-ray of the spine has been finished. Next will be a tutorial. So you may unmute the mic and you can try to answer, because I know definitely within a single class you will not be able to grasp the intricacies of the radiology of the spine. It may take few classes, continuous monitoring, but this class may give a foundation for you to learn how to read the X-rays. It's not that within a class you will never learn the X-ray to the full extent, but it gives a general idea or a basis how to read the X-ray of the spine. And gradually, if you are having an inquisitiveness, if you're having an interest, you can improve upon by continuous practice, etc. So now I'll be having set a few slides which are from my clinical patients, which we had made which we have made a diagnosis out from the radiological studies, and you may try to answer what exactly these conditions are. So this is a X-ray of a 24-year-old boy. He came to me with a complaint of back pain. Actually, this patient has been come from an allopathy hospital. They have been treated with this X-ray. Also has been taken from an allopathy hospital. They tried to treat the patient after getting admitted for 5 days. The pain didn't respond, so the patient came to me with the low back pain. And after seeing this X-ray, I made a diagnosis. So can you say what are the clinical findings you got from this? You all can unmute and try to answer this.
Hello.
Yes.
Can you, sir, explain me HLA-B positive What is the role of HLA-B positive to ankylosing
No,
spondylosis?
answer section will follow later on. Actually, initially, can you just finally you may ask the questions. Now, actually, can you just
Sir,
explain about the findings in this X-ray?
Okay, sir. Thank you.
sir, can I answer, sir?
We will discuss in the light. The flag end actually we'll discuss about. We'll have a question answer session, right?
So the photo, the X-ray is suggestive in the right side at the thoracic area, the fourth rib from the down. There seems to be a fracture in the rib, and the psoas and the psoas
Okay,
shadow
go ahead.
and the psoas shadow is missing on the left side. Maybe some
That's a very,
inflammation.
very good finding. The soya shadow is absent absolutely on the right side. On the left-hand side, you can see a soya shadow here is absolutely absent. That's absolutely right. Then you said there is a fracture of the rib here.
Yes, sir.
Here.
The floating rib is also missing. Yes, sir. This is fracture of
Yeah,
the rib.
the rib is missing. Okay, it's not actually missing. It's a lytic process. It has been distracted. Okay, that's two are fabulous findings. Congrats. Any other findings? I didn't send the patient immediately for an MRI, not because of those findings. I had one more big clue from this X-ray.
Sir, there may be gash shadows, but the transverse process also not being seen in the lumbar. Yes,
Okay.
sir.
Okay, definitely the transverse was not seen. It's not because of a gas shadow. It is because of some infective process. I appreciate that. Good. One more thing. But I have not sent for those reasons. But one more another important finding is there.
So the spinous processes, so they're consistently like their black areas consistently on the last 3-4 spinous processes. So is it
This black you are saying?
No, sir. No, sir.
This.
No, yeah, above this. Yes, sir. Yes, sir. In this.
In this, or what are you seeing?
Just above this, like above the spinous processes, in the upper
This.
1/3 of the bodies. Yes, sir. Yes, sir. These
Okay.
consistently 1, 2, maybe gas shadow or.
These are gas shadows. These are gas shadows. One more. But at one level, it is not gas shadow.
So this is quite big at the lumbar.
No, not in lumbar.
So at the last 3 ribs, the thoracic vertebra, the space seems to be less, and it is some like a chip of little bit.
Is it here?
No, just beneath this. Just beneath this. Yes, sir. Yes, sir. This one.
Absolutely fantastic. This is the area where I have, because this by seeing this will I send for an MRI, because you can see this is I also suspect a gas shadow, but here compared to the disc space, here the disc space is not seen with the lytic lesion here. By seeing this, I immediately send the patient for an MRI. Along with that, here you can see the here soya shadow is there. Here there is no soya shadow. Here there is a rib. Here there is no rib. The rib also you can see there is a lytic destructive lesions are there. And here also the transverse process. Here there's a clear transverse process. Here it is not there. So I sent for an MRI. This MRI shows at the D10 level there is a destructive lesion. Here you can see a destructive lesion here. There is a big paraspinal soft tissue shadow is there. Lot of pus has been accumulated here. There is a collapse of the vertebra, and here you can see this is a big psoas abscess. So because of the infection or transferred from here has flown down and accumulated in the psoas area and leads to a big psoas abscess. Immediately after seeing this, because if you had done some upping or something here, what is this vertebra having collapsed and the patient would have gone into a stage of a POTS paraplegia. So immediately I sent to a neurosurgeon. He said that there's no need for a, because we can't drain this. If you drain, it will not heal. So he has started with the AKT4 treatment and the patient became absolutely fine. So congrats, Dr. Aditya. Just fabulous findings. Great.
Thank you.
Can you diagnose based on this X-ray? Your findings? Everyone can answer. If it is right, wrong, doesn't matter, because I'm a teacher. I am used to hear these wrong answers as well as foolish answers. So you may open up anything, whatever you see, whatever you like to answer, you may come up. Anyone could answer, please.
Type data.
Anyone?
Yes, doctor. Dr. Vindhya have said osteophytes present.
Definitely, osteophytes are present. That's true. Right.
Dr. Nandakumar have said it's pot spine.
It's not port spine because see, one of the important thing is that here you can see a vacuum phenomena. There's a black radialism because vacuum phenomena is not a hallmark of port spine. Here you can see there is a fish vertebra sign. You can see there is a biconjugate disc space structure. There's a reduced disc space, osteophytic lipping. The normal alignment is slightly lost. And signs of a gross demon. It's a case of a severe lumbar spondylosis or a severe degenerative spine. Osteophytic lipping, marginal sclerosis, reduced disc space, vacuum phenomena, curvature is slightly lost. Everything suggests a degenerative spine. This X-ray.
Dr. Sumana have said it is scoliosis.
Definitely, there's a scoliosis. It's called as degenerative scoliosis because here the disc has been damaged. Okay, fine. You can see there's osteophytic lipping is there. Again, marginal sclerosis. Marginal sclerosis is there. Again, a degenerative spine. This X-ray.
Lumbosacralization.
Not lumbosacral, it's a X-ray of the upper spine.
Dr. Aditya have said extra rib.
Yes, definitely it's an extra rib or a supernumerary rib or a cervical rib. Good. This X-ray.
Dr. Kumudini have said sacroiliatis.
No, there is slight sacroiliitis is there, slight actually, but it's not the major finding. Here you can see there is the spinous fossa is not fused. There is a slit in between. There is a gap in between. What is the condition called?
Dr. Aditya have said the edges of vertebrae have scoliosis.
It's called as a
Sir, in the last,
spina
sir,
bifida.
yes, sir,
This
the
is
last
case of
spine.
a spina bifida is there. The spine has not been fused. This is called a spina bifida. Then what Dr. Aditya said?
Sir, the edges of the body are, sir, the more thickened, like more opaque. So sclerosis of the edges and
Sclerosis,
above the
slight sclerosis.
right, above the bifida.
Right. This X-ray, can you make a diagnosis? X-ray has to be viewed from the top onwards. Okay.
Dr. Vindhya have said listhesis.
There's no listhesis.
So the lateral, it's a lateral X-ray of the lumbosacral spine. So the
thoracolumbar spine. It's a X-ray of lateral of the thoracolumbar spine.
Thoracolumbar spine, sir. So at the thoracolumbar junction, there is some fusion at the anterior end. at the vertebra body anterior end. There seems to be some
Okay.
joining.
What could be the diagnosis?
So, the lumbar area, there's some, the edges are not smooth of the vertebra, and there's some osteoporosis.
Okay, fine. Okay, what have you said? This is a sharp projecting osteophytes outwards at the thoracic spine. This is called as diffuse idiopathy skeletal hyperostosis. Very diagnostic of a very sharp projecting osteophytes outward at the thoracic spine. This is called as diffuse idiopathy skeletal hyperostosis. Then the rest of the findings, there is a certain sclerosis here, etc. Now you can see the shiny end here actually at the tip of the vertebra. What you said, this is called Romanus lesion that is generally seen in ankylosing spondylitis, but in diffuse idiopathic skeletal hyperostosis also there will be enthesitis. So this shiny corner is called as Romanus lesion, along with the sharp projecting osteophyte. This is a case of a diffuse idiopathic skeletal hyperostosis or a dish.
Thanks.
Right. Fine. This one. Okay. Can you diagnose this condition? What is this diagnosis? Say X-ray of the thoracic spine.
So the ribs seem to be broken or some kind of inflammation, secondary healing after breakage. Like
it is not that. You can see in a diffuse idiopathic skeletal hyperostosis, there will be sharp projecting osteophytes in the right side. You can see this is the sharp projecting osteophytes outward. This is called as diffuse idiopathic again hyperostosis. It's easy to be diagnosed in an anterior posterior X-ray. It's not the broken rib or a healing, but you have the diagnosis because your findings are right. Actually, it's not a rib pain, but it's a sharp projecting osteophytes outwards. It's not as a process of a callus formation, but it's as a process of the disease process called the diffuse idiopathic skeletal hyperostosis. Good. Can you diagnose this?
the anterior end of the C3, C4 is fused, and
yes, that's there's a bulky osteophytes. I said that usually the bulky osteophytes are like this are seen in two distinct conditions. One is diffuse idiopathic skeletal hyperostosis. Second is a psoriatic arthritis. Here there is a bulky osteophytes with some lytic lesion. So it's a diagnosis of a psoriatic arthropathy. Can you diagnose this X-ray?
the space seems to be increased between the two vertebrae.
Here.
And this
Here?
is the edge
Or
has
here?
sclerosis. Yes, sir. Yes, sir. These
Here.
spaces. Yes.
It is not the disc space is increased, but there is a compression fracture of the vertebra. Compare with the height of the vertebra is reduced, there is a compression fracture of the vertebra. It is not the height space increase, but the bone has been compressed, so it gives a wrong information, a false impression of a disc height is increased. It is a case of a compression fracture following a fall. Clear?
Yes.
This X-ray.
Thoracic spine with lateral view thoracic spine at the upper one third
here
then there's some sort of inflammation in the body of the vertebra below this beneath this and beneath this yes sir, there's some sort of breakage and inflammation.
Yes. This vertebra has been collapse to some extent, lytic lesion with some sclerosis, and here there is no the end plate is not seen. Here you can see end plates are seen, not end plates, sorry, the border is seen. Here the borders are not distinct, it has been distracted by some damage process. So as been referred for, this is not my patient, okay? I taken from my friend's patient. Here you can see this is a port spine again. It's a port spine infection with the lytic lesion. Here you can see there's a lytic lesion. There's an axial view from the MRI. It's a case of a port spine with a paraprevertebral abscess is there. A case of a port spine again. Can you diagnose this?
The alignment is going sideways of all the
Okay.
ribs.
Okay. So it's a case of a scoliosis. The alignment is a case of a scoliosis, a case of an adolescent idiopathic scoliosis. And here the corpse angle is less than 30. So we can definitely conservative manage with our treatments like traction, certain treatments, etc. Okay, fine. Here, can you diagnose this patient? Clinical
So
findings?
between the two vertebrae, the space seems to be less and fused some places, like
Right.
obliterated.
Okay. Obliterated. Right. The space has been completely obliterated. Then.
And so there's tilt. There's left side. This transverse. The
Oh,
left side is the fusion of the above and below. Yes, sir. The bodies of the vertebra.
yeah.
Yes, sir. They're like compressed.
Okay. It is a case of osteophytic lipping with a vacuum phenomena here. Because the disc has been collapsed and there's osteophyte lipping. Again, a degenerative spine, lumbar spondylosis with the osteophytic lipping, degenerative scoliosis, vacuum phenomena, marginal sclerosis. Again, a case of. Okay. So, thank you, one and all. Okay, if you got any doubts, you can ask. Someone was asking about HLA B27 or something. You may, what you're asking, actually, I didn't get to the question completely. Can you just repeat
Doctor,
it?
can you please repeat the question? Dr. Mureshwar Hudar. Doctor have asked one more question. Can you please describe ankylosing spondylosis? Ankylosing spondylosis.
Okay, he was asking about HLA B27, I think. So the diagnosis of ankylosing spondylitis, usually, as I said, the ankylosing spondylitis starts at the second or third decade of the life. That means in the early 20s or 30s is the time which starts. Usually starts as a oligoarthritis. That means sacroiliitis, three or more, less than four joints, there will be pain will be there. The severe early morning stiffness and sacroiliitis will be there. And if you go for a physical examination, lateral bending will be affected and restricted movement of the affected joints will be there. If you doubt ankylosing spondylitis, we need to get an X-ray of the sacroiliac joint. If the patient is affordable, rather than an X-ray, MRI of the sacroiliac joint will be better, which shows a sacroiliitis. So if there is a sacroiliitis with the oligoarthritis, and if you doubt an ankylosing spondylitis, there is a hematological examination called the human leukocytic antigen HLA-B27 blood test, which will be positive in almost about 90 to 95% of the patients with the ankylosing spondylitis. But there is one exception in Asian population. This HLA-B27 may not be that much of positive. In many cases, it may be positive in 45 to 50%. So it's not a very reliable, but clinical science, radiological science with HLA-B27 positive, we can definitely confirm the diagnosis of an ankylosing spondylitis. Now, regarding the treatment, as it takes a little time, actually, we may discuss some other time. Actually, this is about the diagnosis.
Okay, Dr. Sam have asked, can you explain us about transverse neuritis?
Transverse neuritis. I am not aware of that clinical condition. What is transverse neuritis?
Doctor, can you unmute yourself and ask your question? And there is another question by Dr. Aditya. Sir, what is your approach towards management of multiple myeloma, where there is lot of Dhatu Paka and Astikshaya?
My approach towards multiple myeloma is just to refer the patient to an oncologist where he can better manage the condition. I myself will not manage a multiple myeloma because multiple myeloma, if it is referred at an early phase, it can be cured with the help of the modern oncology medicine. So when there is a cure available, it's better let them manage because our treatment may not be that effective in curing a case of a multiple myeloma. So I usually do not treat a patient with a multiple myeloma. Rather, I will refer a patient. I'll show you one example. So this is a patient called PJ Roy. He was almost 54 or 56. I don't remember. It's about 56 or something. Came to me with a pain in the lower back radiating to leg. He had an MRI with him. An MRI taken 2 years back, and in that there was a disc bulge was there. So started treating the patient. After 3-4 days, also the patient the pain didn't respond, and the patient was having severe pain. So I took an X-ray. When I took this X-ray, I found that here there is a lytic lesions. There is a mixed lytic lesions in the vertebrae has been seen. And at the upper area, there is some sclerosis. So a sclerosis with the lytic lesion is there, which grows a suspicion about osteoblastic as well as osteolytic metastasis. And I sent for a protein electrophoresis. This is a protein electrophoresis which I have been sent. And this protein electrophoresis showed there is a M band. It's a peak band. M band is seen at the beta 2 area. And since the patient was only 56, okay, he's only 56. He's only 56. I immediately referred to an oncologist. I think it was in 2019 or 20 at the time of COVID, I think. And they started the treatment, and the patient, I thought actually it was slightly earlier phase of a multiple myeloma. And the doctor also initially said it's at the early phase. They started with the chemotherapy, but the patient had a recurrence. And now the patient has undergone a bone marrow transplant. He is absolutely fine now. So when there is an effective, much more effective treatment in the complementary system of medicine, and when because our priority should be the patient, it should not be our diagnosis or medicine. So in which system, when the patient gets a good treatment, our system comes second. It has to be the patient has to be the health of the patient, and the longevity of the patient has to be given the prime importance. So our treatment may not be that effective in managing the multiple myeloma, and I don't have much experience, and I not attained the sufficient experience to manage a patient with the multiple myeloma. I don't take risk. I refer this patient to an oncologist, and he's absolutely fine now. Not absolutely fine now, but he's still surviving in a somewhat better shape than before. And now it's almost 5-6 years over, and he's still surviving. It's because of the complementary medicine or their efficacy or their effectiveness in managing a case of a multiple myeloma. So I don't treat this patient. I treat whichever can be treated in our system, whichever can be effectively treated. If I find that a better solution is found in other system, I do refer the patient. But I do make the diagnosis and then refer the patient. That's my point.
Okay, sir. Dr. Hudar have said this is a wonderful and great radiology explanation. Thank you, sir.
Okay, nice to hear that.
Dr. Aditya have asked, sir, what would be your approach in myeloma patients with Dhatu Paka?
Sir, you have already explained, sir. Sir, you have already explained, sir. Thank you, sir.
Okay. So many doctors have said thank you, sir. Dr. Kumudini said thank you, sir. Dr. Sridevi said thank you, sir, for your wonderful session. Another question by Dr. Mureshwar. PID in primary treatment injection epidural is okay.
Yeah, definitely. I feel in such conditions rather than an epidural, our treatments are sufficient to manage such cases. There's no need to go for an epidural injections. In such condition, our cardiovascular and anesthesia and other things will work effectively better than that actually, without having any side effects. need to go for such epidural incision.
Okay, sir. Dr. Sagar have said thank you, sir. And Dr. Aditya have said thank you, sir. Any more queries, participants? Please unmute and please ask your questions, or else please put it in the chat box. Please put your queries in the chat box. Please give us the feedback on the session. And also, please, if you have any queries, put it in the chat box or unmute yourself and ask.
If you have got any doubts in the future, you may reach me on this 9946244088 to WhatsApp. I can just answer as in the clinical practice if you find any difficulty where I can help out, or if I have a comment, I can definitely help you out. In the future, you may ask if you got any doubts in the radiological area of any diagnosis. You may definitely reach me out.
Doctor, there is another query by Dr. Bijita. If their D11, D12 disc bulge and disc space is reduced, disc protrusion indenting the hemichord, what is the correlation?
See, correlation definitely. The problem is that the D10, D11 area, that's one of the area which is very narrowest area of the spinal cord. So normally if there is a disc bulge at the D10, D12, D11 and D12, it leads to a condition called as myelopathy. So because the rest of the areas, and then the lumbar spine or thoracic spine, the other areas, the vertebral canal is much widened. But at this level, as the vertebral canal is too much narrowed, if there is a disc bulge, especially if there is a central disc bulge at that side, which can lead to myelopathic changes. If the cord diameter is lesser than 8 at that level, actually, I do definitely suggest for a surgery, because it can damage the cord and patient may land up in a hemiplegia condition. Sorry, paraplegic condition. So the management depends upon the wide or the measurement of the spinal canal. If it is lesser than 8, and if the MRI, if the disc bulge is causing any hyperintense lesion on the cord, that means if there is a myelopathy or if there is a myelomylacia, I may suggest surgery at that part. But if it is lesser than that, if it is not causing a myelopathy, and if it is a minor disc bulge, I definitely manage in the same level how I manage a case of a lumbar intervertebral disc. But only thing is that if it is in the thoracic cord, I will find out whether it is compressing the cord and gives a features of a spinal canal stenosis, like weakness of the limbs, if there is a loss of control of the bowel or bladder, if there is an angle weakness, I may immediately send for a surgery. If such neurological symptoms are not there, if there is no much of the neurological claudication, and if there is no much of the myelopathy changes, I manage it the similar way how we manage a case of lumbar intervertebral disc. Definitely, I advise for a traction. I can advise for a immobilization. I advise for a cardioplasty. Also, at the same time, I advise for a Marma-based, because Marma-based definitely help to function the nerve in a mild compressive condition. But all this depends upon the clinical presentation of the patient, and at what reach the canal stenosis has happened, and what effect it has caused on the spinal cord. If it is only on the thecal side, definitely I'll manage the cause the patient. But if it is compressing the spinal cord, if myelomylacia changes are present with the neurological signs like weakness, bowel bladder is affected, definitely I refer for a surgery. It depends upon the extent of the disc bulge and the presentation of the patient.
Okay, sir. Can you please share us the feedback of the session participants? And also,
it was a very great session, very in-depth analyzation on the X-ray and its radiology. It was very worth to watch the entire session. Very simple and very deep insights, sir. Thank you. Dr. Sri, please read the feedbacks. Okay.
there is one more query, doctor. Dr. Nandakumar have asked, any X-ray, ABN, hip?
X-rays are there, but not in this slide actually.
Okay.
X-rays are there, but in this slide there is no avian X-rays because I focus only on the spine area, not on the other joints. But if you want, if you got any doubts about the avian, I can just clarify it. I don't have any X-rays to be shown, but definitely I can answer if I got any doubts about the avian.
Dr. Nandakumar, if you have any query, please put it in the chat box or unmute yourself. Dr. Anjali have said, thank you, sir. Dr. Vijita have said, very informative session. Thank you, sir. Dr. Anjali Kumari have said, thank you, sir. Dr. Nandakumar Mali have said, it's very informative session. Dr. Sumana have said, can we get the recordings? Yes, the recordings will be available, doctor. And Dr. Danya Ravindran have said, thank you very much, sir. And Dr. Anjali Kumari have said, very useful, sir. Very session was very useful, sir. Dr. Sneha said, thanks, sir. Very informative. Dr. Joshna Maria have one more query. Sir, in a case of congenital fusion of C6, C7 vertebra, can we reduce the symptoms in any way?
So usually it is not the congenital fusion which causes the symptoms. Whenever there is a congenital fusion, that means that is what is a blocked vertebra. So what will happen? Normally, cervical spine got a lot of movements. It has got movements in different directions and magnitude. When two of the bones are fused, the movement of that particular vertebra will be taken up by the disc at the upper level. So usually, if there is a blocked vertebra, the upper level disc bulge is likely to get bulged. The fused vertebra in itself does not cause any symptoms. But because of the fusion, the extra strain happen on the upper as well as the lower vertebrae to that level can get bulged out and cause. So the management will be very similar to that of the cervical IVDP with radiculopathy, and it has to be managed accordingly. The same thing. I do prefer a traction at cervical level. Then a certain Nadi Shweda, I do prefer Nadi Shweda, Marma-based, certain potli massage, Patra potli Shweda, etc. And I try to manage that case. But managing will be on the similar line of the other cervical intervertebral disc as with the radiculopathy. It's not the fusion cannot be corrected, neither because it's a congenital thing. Actually, it does not. We can't do anything on the fused one. But because of the fusion, the upper or lower level disc bulge has to be addressed, and the compressive neuropathy has to be managed. Entrapment neuropathy has to be managed accordingly.
Okay, sir. There is a query by Dr. Sumana also. Is there any remedy for scoliosis in our treatment?
Yeah, definitely. It depends upon, as I said, actually, scoliosis surgery, we should have a good command on the scoliosis. If it is an idiopathic adolescent scoliosis, if the corpse angle, okay, there are certain different schools of thought, as I said, we should understand what we mean corpse angle. If the corpse angle is about 25, I do prefer now if it is about 25, and if it is causing any symptoms, definitely if it is in adolescent, that means before the 18, it has to be sent for a surgery. The corpse angle is lesser than 25. I generally do certain preachles, camras, sarvangadhara. Along with that, I give a traction to the patient. I do a nadi shweda to relieve the muscle spasm. And I do a course of Shakti Shalipanda Shweda. At the same time, I do check their calcium levels, vitamin D levels, and I do supplement that too. Along with our Ashwagandha Ashtam, Ayurvedic Bhasmakar. In that way, I do supplement that. Vitamin D may be supplemented as a supplement. Then I do go for a counter traction to that patient and continuously 2 to 3 weeks of intensive traction with the Pirichil and Shashti Shaili Pindasweda along with the Marma-based. And after that, I advise them to go for vigorous exercises to the paraspinal muscles, certain pull-up I do advise to the patient, certain push-up, and I do advise the patient to lie down on the position where there is a concavity of the curve. Usually, I don't use it braces because there are indication for braces, but braces in practical sense that doesn't give much of the relief. That's what I see because sometimes it may give a deformity to the jawbone, etc., and the patient finds it very difficult. So other line of treatment I do follow, but I do definitely educate the patient's family for the need to have a proper correction. And if it is possible from my side, if it is less than 25 degree, I do prefer. If it is above that, I send for a spine surgeon who performs a scoliotic correction surgery. But you should have a good hold on how to diagnose a scoliosis, what type of scoliosis it is, what is the corpse angle, and when to refer a patient. That's very important. You should not give any difficulty to the patient's future prospects because you don't have a good command on the scoliosis surgery and the scoliosis diagnosis and management. If you have got a good hold, better measure the corpse angle and manage the patient accordingly.
Okay, sir. There is another query by Dr. Aditya. Sir, I need direction for hands-on course or observation in Rasha Shastra. Need your guidance. Is there any government college you would recommend? Any doctors?
For Rashastra, you say. Okay, Rashastra. One Dr. Gopi Krishna is there from Karnataka. He's a very good master in Rashastra. Dr. Muralidhar Sharma from SDM Ayurveda College, Udupi. Is also a very good master in Rashastra. But Dr. Gopi Krishna conducts regular classes in Rashastra. He got an institute, some academy, Indian Institute of Academy, something. I had to forget that. He conducts regular classes on Rashastra and he is a master in Rashastra. But in Kerala, there is one Dr. Nechil is there. He is also a master in Rashastra. He also can guide you in Rashastra.
Sir, any government Ayurvedic college, if you can recommend? Dr. Shashi Kumar is, I think, sir, private, sir.
He's a private, right. But he has got a good command in Rashastra, that's what I said. In government Ayurveda college, Rashastra who are in Kerala, I don't know anyone specifically. I have good knowledge, but I don't know anyone specifically who is better in Rashastra area. I don't know. Government Ayurveda college. Advantage like an inquiry. Dr. Jesul may be joining. You may ask Dr. Jesul as he may guide you properly. So, command in Rashastra.
Okay.
There is another query by Dr. Nandakumar Mali. That is role of Tiktaka Shirabasti in avian.
Yeah, definitely. In avian, there's always some astic shaya or in asti majjagada vada. Definitely, Tikta shira is indicated. So definitely in avian also, asti majjagada shosha is definitely there. So we have to give some medicines to compensate that as in of the dadu shaya. So Tikta shira is indicated in asti majjagada vigaras. Avian being asti majjagada vigara. You can definitely go for a Tikta shira in avian. But depends. If avian also definitely is in all, not all the case of avian actually. If the architecture of the femur is lost, head of the femur is lost, if it is collapsed, then treatment may not be in such condition. It has to be always definitely replacement would be the ideal choice. But if it's like earlier grade 1 or grade 2 conditions, immobilization and offloading of the patient with a continuous traction, then the Tikta Shirabasti or Google with the Grida intake with the Google with the Matra Basti, and they will definitely help in maintaining the restoring the avian and to have a proper life. But it depends upon the stages of the avian. But in the early stages, definitely Tikta Shirabasti, Google with the Grida Matra Basti, and Google with the Tikta and Grida or Google with the Grida intake, etc. will definitely help in managing that. Then Ashigandha Ishta, etc. are medicines which can help in such condition with the offloading of the patient initially for first 1 to 1.5 months, then strengthening the hip muscles with the exercise and certain yoga procedures. It has to be a collaborative treatment effort which may help the patient outcome.
Okay, sir. There is another question by Dr. Danya. Sir, can you explain the line of treatment for female patient aged 49, weight is 111 kg with IVDP, L4, L5 with varicose vein?
Okay, so first thing is that the disc has got a pressure called a particular LB, the intradiscal pressure is there. The particular LB is the pressure where a disc can hold it. And she said the way, she also said that the weight of the patient is 100 and?
It's 111.
Or 111. So that much of particular pressure will not be taken up by the disc. So the first primary focus should be weight reduction. Because as you know, The humans are been designed to walk on 4 limbs, on both the legs and both the hands. Our ancestors, if you see, actually they walk with the 4 limbs. But as when evolution happens, we started walking on the 2 limbs. But because of 2 limbs, what has happened? Our pressure over the disc has been increased. As a result, actually, there is a that result in a distal. In this case, primary focus has to be definitely weight reduction. Then the other treatments will be very similar to that of how we manage IVDP, like Kadivasti, Marma-based, Patra-Podlisveda, Shashti-Shalipandasveda, etc. will be your life. Then other exercises to strengthen the paraspinal muscles to prevent the further distal. Then varicosity, definitely one of the complications of or one of the cause of varicosity is obesity, especially the truncal obesity or abdominal obesity is one of the main reasons. So reduce the weight. That is should be the primary focus.
Thank you, sir. Dr. Joshna Mariam have said thank you so much, sir. Thank you so much for your knowledgeable session. Then Dr. Sumana have said thank you so much for the explanation, sir, for consultation. How to contact you?
So you can contact me. This number is there. Actually, it's 99462440. That's my WhatsApp number. You may contact me directly. Or if you'd like to enhance your knowledge in the radiology, there's a textbook written by me that's also available. You can just WhatsApp me to this number and you can go through that. That gives a good idea. You can contact through this WhatsApp number.
Okay, Doctor. Dr. Nandakumar Mali have also said thank you so much. Thank you so much, sir, for the detailed explanation about the spine and showing all the X-rays and explaining each and everything detailedly. And thank you so much for answering all the queries, even though it is late. Thank you so much, sir, for your cooperation for our students. This means so much for us and our students. I'm waiting for your next session, sir. Thank you so much.
Okay, fine. Thank you.
We'll wind up the session, sir. Thank you.